Yes, sir.
Yes, sir. Right. Okay. Right. So let's start the lecture. Very important lecture known as acute flaccid paralysis. We start off with the case history. Can someone kindly read that?
A 24-year-old woman had developed tingling of her legs 4 days ago. One day later, she noted that she could not rise from a sitting position. The next day, she found walking difficult because of weakness of lower limbs and also noted weaknesses of her upper limbs. 2 weeks prior to the onset of this illness, she has had a diarrheal illness that had resolved in a day. On examination, the muscle power in the lower limbs were 3/5 and in the upper limbs were 4/5. All tendon reflexes were absent. The plantar reflexes were flexor. There was no sensory loss. She was unable to close her eyes completely or wrinkle her forehead. Her GCS was 15/15, but she had a poor cough effort. Her pulse rate was 100 BPM and her BP fluctuated between 90/50 to 180/110 millimeters mercury.
Right. Thank you. So what does BPM stand for?
Beats per minute.
Yes. Right. So now your learning outcomes on the LMS is different to what I have put here. What I have put here are 8 questions related to this patient. Now this is a real life patient whose video I will show you as we go along. Now at the end of the lecture, I'm going to show you these 8 questions, and if you can answer these 8 questions, that means you have learned what you need to know. All right. So the first question in any neurological problem is, where is the lesion? Second question is, what is the lesion? Third question, what is the diagnosis? So you know where the lesion is, you know what the lesion is, and therefore you will know the diagnosis. Fourthly, explain the pathogenesis of the illness. 5, what are the severe complications? 6, how do you diagnose this disease? 7, how would you manage this patient? And finally, what is the prognosis? So this is the same case history I will present to you at the end of the lecture. And at the end of the lecture, if you can answer these 8 questions, then you have learned what you need to know. Okay. So let's start. Acute flaccid paralysis. The term itself is only a descriptive term. It is not a name of a disease. It is a description of a presentation, a clinical presentation. Acute meaning within hours to days. Flaccid is as opposed to spastic. Spastic is where the tone is increased. Flaccid is where the tone is reduced. And paralysis, you all know. So the term is a descriptive term as to how patients present. So the patient presents with a flaccid. When you say flaccid, you know it is more in relation to lower motor neuron. Not that upper motor neurons cannot present as flaccid, but they usually present as spastic. So here you're talking about flaccid. Within hours to day coming with paralysis. So that's the term. Now, when a patient comes with this description or this presentation, we consider certain diagnoses. One of those diagnoses is acute inflammatory demyelinating polyradicular neuropathy. Right? The second differential diagnosis is a spinal cord compression or inflammation. Now, you may recall that we discussed in uncompressive myelopathy about spinal cord inflammation, and then Dr. Stravinsky spoke to you about compressive lesions of the spinal cord. Now, in a spinal cord lesion, we usually expect spastic paralysis or paraparesis. Can someone explain why would a patient get flaccid paralysis with a spinal cord lesion? Anyone?
If the lesion is at the anterior horn cells?
If the lesion is at the anterior horn cell, you're not going to get like spinal cord compression cannot be focal or localized to one side. Or if you take inflammation, I told you transverse myelitis. It's right across the cord. So say a patient comes with transverse myelitis, but has flaccid paraparesis. Can you explain why a patient with upper motor neuron lesion would present with flaccid paraparesis? Anyone else? You would have learned this in physiology. Hello? Come on. There are over 100 of you, so someone should know. How can a spinal cord lesion present with flaccid paralysis? Anyone?
So during spinal shock, there's a period of flaccid paralysis?
Exactly. That is absolutely correct. So that's a physiological phenomenon. What is called spinal shock, you would have learned in physiology, immediately after injury into the spinal cord, be it compression, be it inflammation, there's a period called spinal shock, where you will have low motor neuron presentation as a flaccid paralysis. As time goes by, within hours to days, they will convert into spasticity. Right. And your next differential would be patient coming with a flaccid paralysis. We are now talking about low motor neuron. So here you have a differential diagnosis. This is what we call differential diagnosis. The clinical presentation is acute flaccid paralysis. Your differential diagnosis, one is AITP, other one is spinal cord compression or inflammation in spinal shock, and the third one is myasthenic crisis of generalized myasthenia gravis. Now I did the lecture to you on myasthenia gravis, so I don't need to re-emphasize that it is a low motor neuron problem in myasthenia gravis because the problem is at the neuromuscular junction, nothing to do with the central nervous system. So that is your differential diagnosis. Now how, I'm not going to take myasthenia gravis because I have already taught you that, but how do you differentiate AITP, that is acute inflammatory demyelinating polyradiculopathy, radiculoneuropathy, from a cord lesion? Now if you take weakness is symmetrical in both conditions. Sphincter dysfunction, you remember in the lecture I did on uncompressive myelopathy, I told you the BBS is affected, the bladder, bowel and sexual functions, and that is affected early because all the ascending and descending tracts across the spinal cord are affected. Whereas in AITP, which is a peripheral condition that affects the nerve roots, as the name implies, acute inflammatory demyelinating polyradiculoneuropathy. Sphincter dysfunction is unusual. Plantar reflexes, even though both may be flaccid, even in spinal shock, in a cord lesion, the plantar responses would be extensive. Sensory signs, I told you in a spinal cord lesion, you get a sensory level. And that in spinal cord lesion, a sensory level is a spinal cord lesion until proven otherwise. Whereas in AIDP, you don't get sensory loss. In a spinal cord lesion, obviously, you do not expect anything above the spinal cord. So you do not expect any cranial nerve palsies. But in AIDP, you may or may not get cranial nerve palsy. If you get cranial nerve palsy, you know it favors the AIDP rather than a cord lesion. Is that clear? So this is how you differentiate. So here is a patient who presents with acute flaccid paralysis. You have a differential diagnosis, AIDP, spinal cord lesion or myasthenia gravis. Myasthenia gravis characteristics I have taught you. So here I am just highlighting. Hello? So here I am just highlighting certain typical differentiating factors between a low motor condition and an upper motor condition that might mimic a low motor condition. Okay. Right. So a few definitions. AIDP, acute inflammatory demyelinating polyradiculoneuropathy. If there is something acute, then there should be something chronic. So that is called CIDP, chronic inflammatory demyelinating polyradiculoneuropathy. So how do we differentiate this? We differentiate this thing based on time. Where progression of weakness is less than 4 weeks, we call it AIDP. Where the progression of weakness is more than 4 weeks, it is called CIDP. So it's the same pathology, but the outcomes, prognosis, treatment, and progression are very different in these two conditions. The pathology is the same. Both are demyelinating neuropathies, which you will learn in Dr. Sudha Gunasekara's lecture, right? He will concentrate more on CIDP because I have already done the AIDP. So they have the identical pathology, but the illness, the treatment, and the prognosis are very, very different. And they're different, and we differentiate them based on their progression and the time factor. If it's less than 4 weeks, AIDP, more than 4 weeks, it's AIDP. Right. Now, coming back to AIDP, let's go to the full term first. Before we progress, we'll go back. Now this term, now look at this term, acute. Acute means hours to days. Okay. Inflammatory tells you what is the pathogenesis of the condition. It's an inflammatory condition. What does the inflammation cause? Demyelination. When you talk about neuropathies, there are two types of neuropathies. Axonal neuropathy, where there is axonal damage. Demyelination, where the myelin that covers, insulates the axons are lost. That is called a demyelinating neuropathy, which Dr. Sudha Gunasekara will explain to you. Poly means many. Radicule means nerve root. Neuropathy means peripheral nerve, neuro. And pathy means pathology. So the term itself tells you what it is. Acute, inflammatory, demyelinating, poly, radicular means multiple nerve roots, and peripheral nerves are pathologically affected. So let's go back to AIDP, and you know that the progression in AIDP is less than 4 weeks. So already you know that by the definition. Now under AIDP, there's only one condition you need to learn, and that is called Guillain-Barre syndrome. Why is it called Guillain-Barre syndrome? Because it was described by these French neurologists. There were 3 of them. 2 neurologists and 1 neurophysiologist. So Guillain, Barre, and Stroll. For some odd reason, Stroll has been dropped from the name. He was the neurophysiologist, right? These were described, the first 2 cases were described in 2 soldiers during the First World War. As you can see, it is in 1916, just before you all were born, in 1916. So it's over a century that Guillain-Barre syndrome has been described. Okay. It's over 100 years since its first description. And that is the only condition you need to know under AIG. Guillain-Barre syndrome, in short, we call it GBS. Okay. So first described in 1916 by Guillain, Barre, and Stroll. Right. Now let's learn about Guillain-Barre syndrome. Very important condition. This is a condition that you cannot not know. You are bound to see these patients, several of these patients during your career. And it is usually a neurological emergency. So if you miss this diagnosis, the patient will succumb and you will also eventually succumb. Right. So it's most commonly a post-infectious disorder, meaning it comes after an infection. About 2/3 of patients have symptoms of an infection in about 3 weeks before the onset of illness. So basically, you have to ask the patient when the patient comes, in the last 3 to 4 weeks, have you had a fever? Because we are talking about infections. Have you had any cough or cold? Have you had any diarrhea? Right? Usually, it's upper respiratory tract infection or a diarrheal illness. So any patient who comes with Acuteflaccid paralysis, make sure that you ask those questions. In the last 3 to 4 weeks, did you have a little bit of fever? Because it may not be very obvious. It may be a subclinical sort of illness. They may or may not have fever. They may have just a little cough or cold or a little bit of diarrhea. But you need to ask. They will not think any significance of that or any importance of that to tell the doctor. So unless you ask, they won't tell you. And the most commonest infection after which you get Guillain-Barre syndrome is Campylobacter jejuni, right? Campylobacter jejuni, which causes a diarrheal illness. So that is why we ask for diarrhea. There are other infections also that are implicated in Guillain-Barre syndrome. I have listed those there: cytomegalovirus, Epstein-Barr virus, HIV. Do not forget HIV, because in HIV, During the seroconversion, you can develop Guillain-Barré syndrome. Mycoplasma pneumoniae, Haemophilus influenza, Zika virus. Zika virus is a flavivirus. And of course, your favorite SARS-CoV-2 COVID virus. Okay. So these are the infections. So just to summarize, Guillain-Barré syndrome is a post-infectious disorder. In about 2/3 of patients, you will be able to elicit a preceding infection. The patient doesn't know the connection between the two, so the patient will not mention it to you. You need to explore it in the history. Ask, do you have fever, diarrhea, cough? And these are the common infections that you need to know or test for if you are suspecting, you're looking for a preceding infection. What are the clinical features? The first symptoms are sensory. Remember that. The first symptom, now you see the word I have used there is symptoms. And I have put it in italics because you don't get sensory signs. You only get sensory symptoms. So the patient will develop some pain, develop numbness and paraesthesia. And the patient will say, Doctor, mata hiriyakawa isala kakul deke hiriyakawa. And then it rapidly progresses within hours to days. Bilateral symmetrical weakness of lower limb. So the patient will say, Angelitica kakul angelitica isala hiri vetuna ude venokota. Dawal venokota kakul deke udata පණ නැති ගතියක් ආවා. ඇවිදින්න අමාරුයි, අල්ල අල්ල ඇවිත්තා. හවස් වෙනකොට ඇවිදින්නම බැරි වුණා. ඊට පස්සේ අත් දෙකෙත් පණ නැති වුණා. බඩු අතින් වැටුණා. Right? So it's a rapidly progressive bilateral symmetrical weakness of lower limbs that ascends to the upper limbs and then to the cranial nerves. So from below upwards. So that is why it's called an ascending paralysis. Okay, ascending paralysis. Then of the cranial nerves, what it affects most commonly are the facial nerve, low motor neuron, bilateral facial nerve palsy. It also affects the bulbar nerves. I told you about the bulbar nerves yesterday. Bulbar nerves are nerve muscles that are innervated by cranial nerves that arise from the medulla oblongata. So that subserves the function of dysphagia, speech and swallowing. So these patients with Guillain-Barré also will develop dysphagia and dysarthria. They will also develop bilateral facial nerve palsies. So it's an ascending paralysis. It can occur over hours, it could occur over days. So let's say in day 1, the patient has lower limb weakness. By about day 2 or 3, they develop upper limb weakness. And by about day 4, they might develop bilateral facial nerve palsy and dysphagia. Okay. There is global areflexia. What does global areflexia mean? Does that mean that all over the world there are no reflexes? No, that is not what it means. What global areflexia means is that now say the patient, you can see the patient at any point. You may see the patient at the point of, at the very onset. You might see the patient a little bit later. So if you see the patient, when he comes only with lower limb paralysis, you're only seeing a patient with paraparesis. Upper limbs will be normal, right? So it's only lower limb paralysis. Then when you do reflexes, because it's a low motor neuron in the lower limbs, low motor neuron lesion, you expect the lower limb reflexes to be absent or reduced, which is there. That's fine. That is expected. But what we see in Guillain-Barré is when the upper limbs are not affected, when the muscle power is normal, still the reflexes are absent. That is why we say global areflexia. So at any stage that you see the patient, even if the patient comes with lower limb weakness, upper limbs are normal at the point you are seeing, still the upper limb reflexes will be absent. So all the reflexes in the patient will be absent. That is what we mean by global areflexia. So that is a characteristic feature of Guillain-Barré. There are no sensory signs. Like I told you when I started off saying, they have sensory symptoms. They talk about paraesthesia. They talk about numbness. They talk about hiria, but there are no signs. When you examine for signs using a toothpick, cotton wool, you don't see any signs. Okay. Now here's the patient that you read out, and this is her case. So you can see she can't close her eyes, even though she attends. So there's weakness of the orbicularis oculi. And then she's asked to smile. She can hardly smile because of the facial muscle paralysis. So that is what you see in bilateral facial nerve paralysis. Right, now progression, you already know AIDP is up to 4 weeks. Now you can see a ascend, the blue line. Watch the blue line. It is ascending. If it continues to ascend beyond 4 weeks, the weakness gets worse, that is CIDP. But in AIDP, after 4 weeks, it gets better. The weakness gets less and less. That is the definition how we define AIDP and CIDP. What is the red line? The red line is what we actually see in real life. Although the definition is 4 weeks, the majority of patients, 80% of patients will reach their maximum in 2 weeks. So these 2 weeks, the first 2 weeks are crucial. First 2 weeks are crucial. That is the first 2 weeks in which the patient will develop all the complications and die. The first 2 weeks, the patient can develop respiratory paralysis and die. The first 2 weeks, the patient can develop autonomic dysfunction and die. So never discharge a Guillain-Barré syndrome before 2 weeks. Is that clear? Okay. So because you know the majority of them will continue to progress up to 2 weeks. Although by definition, they can progress up to 8 weeks as shown in the red line, the blue line. The red line is what we see in real life. So as defined, does not progress beyond 4 weeks. Majority of patients, it is usually up to 2 weeks. What are the complications of Guillain-Barré syndrome? There are 2 complications. Please repeat after I say. One is respiratory muscle paralysis. Say that again to yourself. Say aloud, respiratory muscle paralysis. And the second one is autonomic dysfunction. There are many complications of Guillain-Barré syndrome, but I just want you to remember these 2, right? So say again, respiratory muscle paralysis, autonomic dysfunction. And these 2 are potentially fatal. The patient can die, right? From either one of these. So they don't occur together. They don't need to occur together, but they can occur together. Even when they occur alone, they can kill the patient. Right? So they are potentially fatal. Please memorize this. In Guillain-Barré syndrome, why we are so worried about these patients are because they can develop respiratory muscle paralysis and autonomic dysfunction. How do we diagnose Guillain-Barré syndrome? Now, I took a lot of time to explain to you the typical clinical picture, because the diagnosis is based on the typical clinical picture of acute flaccid paralysis, ascending paralysis, no sensory signs, only sensory symptoms, global areflexia, a preceding infection. That is a full house, a typical clinical presentation. You don't need anything else to diagnose Guillain-Barré syndrome. So a good history, a good examination, and you have got your diagnosis, right? We do use few supportive evidence. One is the nerve conduction study, which we will hear in the next lecture in more detail. Now, in nerve conduction studies, we can differentiate axonal neuropathies from demyelinating neuropathies. I already told you Guillain-Barré syndrome is a AIDP. D stands for demyelinating. The majority of neuropathies are axonal. There are only a handful of demyelinating neuropathies, and Guillain-Barré is one of those. So if the neurophysiologist does the nerve conduction study and says it's a demyelinating neuropathy, then it further supports your diagnosis. Okay. But there's a catch, there's a problem here. What is the problem? The problem is this nerve conduction changes become most obvious after about 2 weeks. And I told you already, nerve conduction become very obvious, then it is too late to be of use in the management. Of course, the clever neurophysiologists, they have special ways in which they say F wave is absent. This is consistent. They can't always say it's demyelinating. They say it's consistent with a demyelinating pathology. So they kind of try to support you, but they can't give a definitive diagnosis. So your definitive diagnosis always depends on your clinical impression. And that is why I spent so much time describing the clinical syndrome. Then, of course, you can do a lumbar puncture. Now, when you do a lumbar puncture, on the CSF, you get a typical CSF. What is this typical CSF? It's called albuminocytological dissociation. Albuminocytological dissociation. What it means in simple words is there is a high protein but no cells. High protein, no cells in the CSF. Okay. The normal CSF protein is 20 to 40 milligram per deciliter. Here the protein will be elevated. It will be more than 40 milligram per deciliter. But no cells. So that is what is typical. But again, there's a problem here. There's a catch. The CSF change occurs only 10 to 14 days after the onset of illness. So its clinical utility is very little. I personally don't do lumbar punctures on patients with Guillain-Barré syndrome because it's too late. It's of little use, and I already have the diagnosis on my clinical impression. The only time I do a CSF examination or lumbar puncture in Guillain-Barré syndrome is when there are atypical features, when I'm not sure of the diagnosis. Right? When there's some doubt, that is when you do the LP. You don't routinely do LP. Okay. But different clinicians will differ. So when you work in different wards, different neurological units, you will see some neurologists routinely do lumbar punctures. But I find there is no clinical utility if the diagnosis is obvious clinical. So that is your cornerstone of diagnosis. What is the pathogenesis of Guillain-Barré syndrome? Now we already know that it's the acute inflammatory demyelinating polyradicular neuropathy. We already know that it is a post-infectious condition. We already know that Campylobacter jejuni is by far the commonest infection, and that is something that causes a diarrheal illness. But there are other infections also that can precipitate Guillain-Barré syndrome, like HIV, Epstein-Barr virus, cytomegalovirus, varicella zoster virus, Mycoplasma pneumoniae, and COVID SARS-CoV-2 virus. Right. Now watch my little cartoon, not very pretty, but it gets the message across. So here's the animation. Here are the Campylobacter jejuni. Okay. When they invade the body, there are antigen presenting cells who will break down the Campylobacter jejuni and present the Campylobacter jejuni to the specific immune cells, the T cells and the B cells. Right. So from your first line of defense, it goes to the second line of defense, the T cells and the B cells, lymphocytes. And what happens is that this would be the cofactors, the cytokines, the antigen presentation to the B cell will transform the B cell into a plasma cell. Now plasma cells can produce antibodies, and that's exactly what they do. So the whole purpose of the antigen being presented to the immune system is to produce antibodies, and the antibodies to destroy the invading pathogen. Now here the invading pathogen, we have taken an example as Campylobacter jejuni, but you can substitute that with any of the potential infections. So the antibodies will be specific towards Campylobacter jejuni to destroy them. So what happens is there are antibodies, and the antibodies will destroy the Campylobacter jejuni. But there is a problem. What is the problem? These antibodies cross-react with myelin gangliosides. On the myelin, you can see here is your nerve. This is a cartoon of the nerve. This is the nerve cell body, axon, and the dendrites. And covering the axon in yellow is the myelin. And in the myelin, there are proteins called myelin gangliosides. What happens is that there's a cross-reactivity of these antibodies that are aimed at Campylobacter jejuni that cross-reacts with the myelin gangliosides. This is called molecular mimicry. So learn that term. It is called molecular mimicry. Mimicry means, mimicry is looking alike. Because the ganglioside proteins look like the Campylobacter jejuni, the antibodies accidentally, not intentionally, accidentally bind them. And as a result, there is demyelination of the nerve roots. There's no damage of the axons, but there's demyelination. With time, there is remyelination because myelin will repair and it will regenerate and the nerve will return to normal. So Guillain-Barré syndrome is a potentially reversible condition, provided you do not let the patient die during the acute phase of the illness. Now that is an animation for you to see. Now you can see what I just described to you. So you can see the electrical current going very fast. When there's demyelination, it goes very slowly because, nerve conduction is through the nodes of Ronvier. So if there's no myelination, the speed slows up. When there's myelination, conduction is very fast. Now see how it slows down there. And then with time, there's remyelination. And the nerve recovers. And the nerve conduction comes back to normal. Okay. Watch again one last time. Okay, so we have gone through what Guillain-Barré syndrome is, that it's an AIDP, how you differentiate AIDP from CIDP. We have talked about the typical clinical presentation of Guillain-Barré syndrome. We have spoken about how you diagnose Guillain-Barré syndrome clinically, neurophysiology and CSF. We have talked about the complication, two most important complications of Guillain-Barré being respiratory muscle paralysis and autonomic dysfunction. And then we spoke about the pathogenesis of Guillain-Barré syndrome. Now we come to the management of Guillain-Barré syndrome. There are 5 major domains of management. One is monitor progression. 2, prevent and manage potentially fatal complications. 3, general care. 4, specific therapy. And 5, rehabilitation. So again, when you are studying, when you are learning something, it is always good to categorize them, to classify them. Of course, again, when you categorize or classify, it has to be something that that would be easy to your memory, not something complicated. So it should be simple like this. So you categorize into these 5 areas, and when you see a patient, always ask, have I covered these 5 areas? Progression, complications, general care, specific therapy, and rehab. Let's go through each one. How do we monitor progression? What is the problem in Guillain-Barré syndrome? It is the paralysis. We are worried about paralysis. We are worried about the complications. So every day as a house officer, when you go to see the patient, you will have to measure the muscle power. Now, how do you measure muscle power? And you must document it. You document it on the MRC grading. So we grade muscle power from 1 to 5, 0 to 5, right? So don't go and write on the ticket, patient is strong. Next person come and say, he's very, very strong. Then the other person comes and say, he's slightly weak. So that is not a universal denominator that anyone can understand, right? So you must have something that is reproducible so that everybody can understand. So everybody use the MRC grading, 0 to 5 muscle power. Then you must monitor for the potentially fatal complications. Now I told you there are 2 things that you cannot afford to forget. One is respiratory muscle paralysis and the other one is autonomic dysfunction. Let's talk about respiratory muscle paralysis. So how do we check whether the person's respiratory muscles are working? The most important thing is the vital capacity, right? The normal vital capacity is 75 ml per kg, right? So what is your vital capacity? Subodhini? What would be your vital capacity roughly? Anka ganite.
About 3 liters.
So roughly any person, it will be about 3 to 4 liters. So about over 4 liters. Okay. So that's a large amount. Now, when the vital capacity reduces, we have to take the patient to the intensive care unit with the potential that the patient is going down. So we need to ventilate the patient electively. So at which level do we take the patient to the ICU? So we have rough guidelines. Anyone? Any guesses? And we always talk in terms of kilograms because each individual is different in size. So if one person is 60 kilogram, other person is 50. So based on that, that is why we talk in terms of kilograms. So say in a large person, in 70 kilogram person, he'll have up to 5 liters of vital capacity. So when do you take the patient or admit the patient to the ICU? Anyone? Yes, if you don't know.
50% reduction.
50%. Now we go a little lower. So it's about 20 ml per kg. Right? So if you take a 50 kg person, it is about 1000 ml, 1 liter. So you say you have about 3 to 4 liters of vital capacity. But if your vital capacity is 20 ml per kg or rapidly declining, very important, rapidly declining, then we admit the person to the ICU. And when it's 15 ml per kg, we electively ventilate. All right. Now, these are very important. Why is it so important? Because we don't wait till the patient go into respiratory paralysis to ventilate. That's a very important concept, very important take-home message. In Guillain-Barre syndrome, we know the patient is going to develop respiratory muscle paralysis. Not all patients develop that. So we have to carefully monitor all patients with Guillain-Barre syndrome to find out which patient will go into respiratory muscle paralysis. And we have to know it much early, so that we electively ventilate the patient before the patient go into respiratory muscle paralysis. Can someone tell me why? Muddanayaka, why? Can you think of? Why are we so particular about ventilating elective and not wait till respiratory muscle paralysis? Anyone?
Because if the respiratory muscle is paralyzed, then due to respiratory failure, the patient might die.
Patient මැරෙනකන් ඉන්නේ නෑනේ ළමයෝ. Patient is in the ward. If the patient dies, then you're a useless doctor. Patient is in the ward. We usually now in the ward, you would have seen when patients have respiratory arrest, they are intubated, ventilated. I am telling you, don't wait till respiratory arrest. You anticipate it by measuring the vital capacity. And by 15 ml per kg, patient is still breathing alone. But we paralyze the patient and intubate, ventilate before the patient has a respiratory arrest. I'm asking you, why are we so specific about that?
Brain hypoxia is irreversible.
Exactly. Very good. I mean, we want to protect the brain. The brain can survive only few minutes without oxygen. And if you know a condition is going to cause respiratory arrest, if you wait till the respiratory arrest, then you are silly. You are ignorant. You are negligent if you wait. So although I'm talking about Guillain-Barre syndrome, many patients in the ward, even myasthenia gravis or any other condition, if you know that the patient is you are anticipating the patient in the next few hours is going to go have a respiratory arrest, then you must ventilate before the respiratory arrest. Otherwise, the patient will develop irreversible brain damage due to hypoxia. Then even if the patient survives, that's useless because the patient is going to have irreversible neurological deficits, CNS deficits. So that is why we measure these things. Now, these are only rough guides. Now, you are working in a hospital, saying a patient is sent to you. Why we give these values are because now say when the patient comes, the first vital capacity you do is 20 ml per kg, you immediately admit to the ICU. right? Now, if the patient is with you and you are measuring it is 75 ml per kg, 4 hours later you do it is 50 ml per kg, 4 hours later it is 30 ml per kg. You're not going to say, no, in the lecture they told 20 ml per kg, let's wait till 20. No, you don't wait. You can see the decline. So then immediately you must admit the patient to the intensive care unit. Okay. Now, how do you measure the vital capacity? Anyone? What instrument do we use to measure the vital capacity? Anyone? It's called a respirometer. Okay. Respirometers are not available. They are very difficult to find. Only certain places have it. Certain ICUs would have it. Certain wards would have it. A respirometer costs over 500,000 rupees. It's very expensive. So when you don't have a respirometer, then we look for a single breath count. What is a single breath count? You ask the patient to take a deep inhalation and in a single breath count. 1, 2, 3, 4, 5, 6. Count and tell me what your count is. Come, soon. Take a single breath and count on expiration. Single breath. Go. Tell me what your count is. I'm going to ask you randomly. Go. I can't see you doing it. Take a single breath and count. How much can you count? Udari, how much? What's your count? What's your count? Anyone?
35, sir.
35. Right. So usually single breath count is over 25. Normal person should be able to count more than 25 in a single breath. If the count is rapidly declining, then you need to admit the patient to the ICU, right? Because we electively ventilate. No point asking your questions. No, you don't answer. No point. If you all want, you can switch off your videos also. It doesn't matter. Right. So we measure, we monitor these patients every 2 to 4 hours. And once they're stable, we monitor them 6 to 12 hours. Right. What about peak expiratory flow rate, pulse oximetry, arterial blood gas, respiratory rate? Those are different ways in which we measure respiratory muscle paralysis. Right. The peak expiratory flow rate is something that we use for what? Anyone? I can upload my lectures instead of, having live lectures. I can upload my lectures into the LMS and you can watch it. I'm just trying to be interactive and trying to teach you something and none of you want to talk. It is very frustrating and it is, you are the first batch that I'm having like this. Other batches, they just, answer. It is frustrating just, giving a lecture to a screen. So from next lecture, I will upload all the lectures. You can have a watch. So it's not live at all. Yeah, I'm taking my time to give you a live lecture to teach you something you don't want to answer. You don't want to speak. You don't want to participate. What is the point? Do you want to do that or do you want to have a live lecture?
Live lecture.
So then why don't you answer?
So to differentiate obstructive and constrictive pulmonary disease.
Yeah, that is what you use, peak expiratory flow rate. That is for obstructive airway disease. It is not for respiratory muscle paralysis. So it's a useless test for respiratory muscle paralysis. What about pulse oximetry? How useful is it for respiratory muscle paralysis or respiratory failure? Anyone?
You can measure the saturation. If the muscles are paralyzed, the patient will be desaturated.
How useful is it in monitoring patients with Guillain-Barré syndrome?
Saturation can be reduced due to several reasons, including ventilation or perfusion ratio. If there's any problem also.
Yeah, the thing about saturation is, you know, the oxyhemoglobin curve. It is a sigmoid shape curve. So beyond a certain point, it will precipitously drop. And by the time the pulse oximetry drop, the partial pressure of oxygen is less than 60 millimeter mercury, right? Now, if you take 93% of oxygen saturation, we are looking for saturation to be more than 93. But the minute it drops below 93, then it is far gone. The saturation is far, the partial pressure of oxygen has dropped already. So it is too late. By the time the saturation drops on pulse oximetry, even the man next door knows this person is in respiratory paralysis. What we are trying to do in Guillain-Barré syndrome is to anticipate, to know before the patient goes into respiratory muscle paralysis, to get clues, indication that this patient is going into respiratory muscle paralysis. Not wait until he goes into respiratory muscle paralysis. For the same reason, arterial blood gases are too late. What about respiratory rate? How useful is that? What about respiratory rate? Exactly, it will increase, but it is, you know, again, by the time the respiratory rate reduces, it will increase with hypoxia, but in the patient with Guillain-Barré syndrome, they have respiratory muscle paralysis. So when there's respiratory muscle paralysis, you cannot appreciate the increase in respiratory rate because it will be shallow. And even if the respiratory rate increases, he cannot do it because the muscles are paralyzed. So again, respiratory rate is not very useful in respiratory muscle paralysis. So basically, all these four are not sensitive, too late, and of little value. So in a patient with Guillain-Barré syndrome, don't waste time with these things. What you have to monitor in a patient is the vital capacity. If you have a respirometer, please everybody go and look at the vital respirometer, because we give the respirometer at the final exam, at the Viva, at the OSCE, we give you the respirometer for you to identify. Because these are instruments, equipment that we use day to day in our wards. Our ward has a respirometer in the prof unit, right? So have a look at it, what it looks like. It is also available in ICUs. So that, and you should know how to use it, because this is life and death. This is how you save a patient's life with Guillain-Barré syndrome. These other things are useless. So if you do not have a respirometer, then you go for the single breath count. And it is all about anticipation, anticipation, anticipation. If you feel this patient is progressing in terms of respiratory muscle paralysis, get him into the ICU. So very important. Right. So then we talk about autonomic dysfunction, the other major adverse complication of Guillain-Barré syndrome, where you have fluctuation, wild fluctuations of the pulse rate of heart. Blood pressure suddenly goes up to 220, 150, next moment it is 80/60. Now, if that occurs, if there's autonomic instability, you can't manage the patient in the ward. You need to get the patient into the ICU, because there has to be monitoring, and that is very symptomatic treatment. When the blood pressure drops, we give fluid boluses, we give noradrenaline, we give dopamine, we give dobutamine. When the blood pressure is high, we give IV antihypertensives like labetalol, right? GTN infusions to keep the blood pressure. Same with the pulse. Sometimes we put pacemakers if the person has severe bradycardia, because these are potentially fatal. They can kill the patient of a disease that is otherwise completely reversible. Right. So supportive care, if there are autonomic fluctuation, get the patient into the ICU. Now general care. Now you know it is ascending paralysis. You know it affects the cranial nerves, including bulbar muscles and the both facial nerves. Now, the problem is the patient will recover in a few weeks if you manage the patient properly. But because of the facial muscle paralysis, as you saw in the video, the patient cannot close his eyes. Right? The orbicularis oculi are weak. And because the patient can't close the eyes, there will be corneal ulceration, drying and ulceration. And when the patient recovers, the patient is blind. So pay attention to the eyes. We put artificial tears, and in patient who has, dry eyes, we may even go for a tarsography. You have to prevent deep vein thrombosis. Here is a paralyzed patient. So we use stockings, we use heparin. Check for swallowing, very important. I told you the bulbar muscles are affected. So if the swallowing is dysfunctional, then we use nasogastric tubes and prevent aspiration. Skin care, bowel care, bladder care, those are important in a patient who is paralyzed. So in skin care, very important, because these patients are paralyzed, they can't turn around. You have to take the pressure off the pressure points. You have to use what is called an air mattress. We have air mattresses in the ward. So these are the patients that we allocate those limited air mattresses to. Bladder and bowel care, make sure that the patient passes urine, open bowels. Recognize and treat pain. Now, when there is a radiculopathy, as in Guillain-Barré syndrome, when the nerve roots are affected, there is pain, very severe pain, excruciating pain. Not all patients, some patients. Now, when some patients get this severe pain, you must give them adequate analgesia, sometimes even opioid analgesics. Now, what is the specific therapy for Guillain-Barré syndrome? The specific therapy, there are two specific therapies. One is intravenous immunoglobulins. The other one is plasma exchange. So there are only two specific therapies for Guillain-Barré syndrome. One is IVIG, the other one is plasma exchange. What do this treatment do? They reduce the time to recovery. So in a patient who would take several weeks to recover, it will reduce that time to recover. It will also reduce the number of patients going into respiratory failure and requiring ventilation. So that saves you from having to find an ICU bed. And also it has been shown that it reduces the disability on the long term. So for these reasons, we use this specific treatment upfront, early in after the diagnosis. The other reason why we use it early is because it is not beneficial beyond 4 weeks. Now, sometimes patients from the peripheral hospital is transferred to us 6 weeks after the onset for IVIG. We transfer the patient back saying there is no point because the IVIG is of no use. Because the IVIG, the greatest utility is when it's given in the first 2 weeks. Same with plasma exchange. Beyond 4 weeks, you already know the disease is not going to progress beyond 4 weeks. So you don't give IVIG or plasma exchange beyond 4 weeks. So it has to be given within the first 2 weeks. That is when the complications are maximum. Now, the whole purpose of giving this treatment is to improve recovery, prevent respiratory failure, and reduce disability. And that efficacy comes only at the beginning. And there is no difference between the two. Intravenous immunoglobulin is as effective as plasma exchange and vice versa. There is no place for corticosteroids. So we do not give prednisolone, we do not give methylprednisolone or anything else. So that is the greatest difference between AIDP and CIDP. In CIDP, the mainstay of treatment is steroids. In AIDP, which is Guillain-Barré syndrome, the mainstay of treatment is IVIG and plasma exchange. No place for steroids. And finally, the fifth component. So the first, I told you the management, we are looking 5 categories and make sure all 5 are completed. So these are tick boxes. So you have done all the 4, now you come to the last one, which is rehabilitation. And you have to start, here is a paralyzed patient. You have to start physiotherapy early during the course of disease. And you start rehabilitation as soon as improvement starts. So rehabilitation means getting the patient back to his normal activities of daily living, right? Physiotherapy from day 1, as soon as the patient comes, so that the muscles don't wear, there are no contractures and nothing happens, right? Here is a reversible condition. So we do not want any other motor complication when the patient recovers. Finally, prognosis. About 30%, that is 1/3 of patients develop respiratory failure. I told you not all patients develop respiratory failure, but we monitor all the patients to identify which patient will develop respiratory failure. We anticipate it and treat it before the patient has a respiratory arrest. That is the take-home message. That is why I spend so much time trying to tell you how to monitor respiratory function in Guillain-Barré syndrome. And that is why I emphasize the importance of giving IVIG plasma exchange early in the first 2 weeks, so that you prevent this 1/3 who goes into respiratory failure. Whatever you do, about 5% of patients will die, even if you put in the intensive care, whatever you do. So it is a condition that has a mortality associated. The majority of patients will improve. 65% will be able to walk independently by 6 months. Now, often when a patient gets paralyzed, obviously the patient is very anxious, and the patient will continue to ask you, doctor, mawa saneepa veida? That's the first question. Kochchara kali yayida mata saneepa wenna? Mata aapo evidenda puluwan veida? Mata aapo duwanda puluwan veida? Right? So there will be so many questions related to prognosis. So that is what we are teaching you here, so that you know the rough time frame. So you say, okay, most patients will recover by 6 months. So give it time, do your physiotherapy, do your rehabilitation. Okay. Overall, 80% recover completely or with minor disability. So that is the good news. And because it's such a recoverable condition, because it's such a salvageable condition, that you cannot afford losing a patient, right? You cannot afford a patient with Guillain-Barré syndrome to die, because it's a completely recoverable condition. And that is why there is a separate lecture in the neurology module. We won't teach you again this thing, but you will see enough and more patients when you come to our professorial appointment. During the neurology appointments and rotations, you will see patients. In other medical appointments, you will see patients. Guillain-Barré syndrome is common, and at the moment we are having a bit of an epidemic, right? So in summary, Guillain-Barré syndrome is by far the commonest cause of acute-flaccid paralysis, and for your purposes, it is the only cause of acute-flaccid paralysis. As far as you know, of course, your differential diagnosis when a patient comes, you will consider spinal shock phase of a cord lesion or generalized myasthenia gravis. It can progress into respiratory failure within hours to days. So if you do not act, the patient can die. Close respiratory monitoring is mandatory. That is the most important thing in Guillain-Barré syndrome. Timely ventilation will save life, not only life, it will also save the brain. Autonomic dysfunction requires supportive care, and if you identify that, you need to get the patient into the ICU. IVIG and plasma exchange are the specific treatment. That is only one of the 5 treatments. I told you the 5 categories. Make sure that all 5 are done in the patient. But the specific therapy is IVIG and plasma exchange, and it has to be given as early as possible. So we come back to the case history. 24-year-old woman had developed tingling of her legs 4 days ago. 1 day later, she noted that she could not rise from a sitting position. So just 1 day later. The next day, she found walking difficult because of weakness of lower limbs, and also noted weakness of her upper limbs. 2 weeks prior to the onset of this illness, she has had a diarrheal illness and that had resolved in a day. On examination, the muscle power in the lower limbs were 3 out of 5, and in the upper limbs 4 out of 5. All tendon reflexes were absent. The plantar reflexes were flexor. There was no sensory loss. She was unable to close her eyes completely or wrinkle her forehead. Her GCS was 15 out of 15, but she had a poor cough effort. Her pulse rate was 100 beats per minute, and her blood pressure fluctuated between 90/50 to 180/110 millimeters mercury. Where is the lesion?
Peripheral nerve, sir.
Nerve root and peripheral nerve. What is the lesion?
Demyelinating lesion.
Demyelinating lesion. Good. What is the diagnosis?
Guillain-Barré syndrome.
So only one person is answering. This lecture is only for one person. Explain the pathogenesis of the illness.
Molecular mimicry causing antibody production against myelin.
Good, excellent. What are the severe complications? Someone else?
Respiratory failure and autonomic dysfunction.
Good. How do you diagnose the disease? Someone else?
Clinical diagnosis.
Yeah, it is clinical diagnosis supported with, if necessary.
Physiology and CSF analysis.
Yes, if necessary, generally, your main diagnosis is clinical. How would you manage this patient? We went through these 5 components, which you don't need to repeat. What is the prognosis? Majority will recover, 80% will recover, provided you don't let the patient go into a respiratory arrest or have a cardiac arrest due to autonomic dysfunction. Okay. So to end the lecture, the same patient, watch her before and after treatment. So here you can see during the illness, she cannot wrinkle her forehead. She cannot close both eyes. So she has a bilateral low motor neuron facial nerve palsy. And then you ask her to smile. She can't even smile because both sides of her facial muscles are paralyzed. 4 months later, same patient. She's asked to close her eyes. You can see now she can screw her eyes closed very tightly. And you can see the eyelashes burying into the skin there. And then that is the smile. That is the smile we wait for. And that is the smile. That makes it all worth when you properly treat a patient. The opposite also is true. It can be